So my talk will be giving you a little background and emphasize why it is needed to look for alternative preparation methods in the hospital pharmacy, such as the 3D printing. We have had a long-term collaboration with the hospital pharmacy at the University Hospital in Oslo, where we have looked at together with clinical pharmacists and the pediatric clinic how drugs are given to children, what type of drugs do they get, a lot of the unlicensed and off-label drugs, do they manipulate the drug dosage form, and so on. So I will start by giving you a short introduction to what some of the findings in that project. Um, it was done a registration in two of the largest hospitals in Oslo in the children's wards, where we found that approximately 70% of the prescriptions was either off-label, which is used for an indication that it's not approved, an age group that is not approved, or an administration way that is not approved, or it was unlicensed drugs in Norway. And as we can see, this was found in all age groups, from the very young newborn, both preterm and term born, and up to the adolescent patients. When it comes to what type of drugs are manipulated, it was, of course, as expected, mostly tablets and capsules. And not only were the dosage form manipulated, but it was manipulated with a reason to give a segment of the dose, because, of course, needed to adjust the dose to an adult dosage form to a child-friendly dose. And this is a summary among the age groups, showing that the very young had a lot of issues regarding the appropriate strength of the drug, but also equally important is that it was an unacceptable dosage form for the kids. What was a bit surprising to us is that the age span from 2 to 5 years were much lower than the 6 to 11 years. But when we looked at the kids that were involved in the observation study, um, quite few kids were in the age span 2 to 5, which explains why this was very low. And also, my maybe a bit surprising is that the 6 to 11 years, a lot of the we learned that from maybe age of 6, children can learn to take tablets, and they can be trained at that if they are chronically have a chronic disease. But as much as approximately 1/3 of the administration that was registered was either manipulation and a segment given, or manipulation in order to give the full dose. And we found that this was so interesting that we wanted to check what does the manipulation um, do with respect to dose accuracy and the precision of the dose that is been given. So we have studied some drug substances, and I want to show you some of the results from the acetylic salicylic acid, because this was frequently manipulated in the study. There are several types of tablets available on the Norwegian market. We noticed that in the children's ward, they tend to use the chewable baby aspirin tablet. And we will come back to that because, of course, when a dosage form was introduced to the market, which was specially made for children, it is easy to think that this would be the best choice, but that depends on how you will administer the tablet. Um, but as I said, we chose ASA, and it is a polysoluble drug substance, so it works also as an illustration of a polysoluble drug. And last but not least, it was a well-characterized drug substance, so that we had analytical methods, stability data, we knew the degradation kinetics, so on and so forth. So we chose to continue with some studies with acetylic salicylic acid, and we both split the tablets and we dispersed the full tablet, and we looked at different ways of dispersing and those extraction methods. The 4 tablets that was chosen was one effervescent tablet, one conventional tablet, and 2 tablets that are specially targeting, at least one tablet that is specially targeting the kids, which was the Bayer chewable, and another aspirin dispersible tablet. And when we looked at the guidelines that the nurses are relating to on how to administer these drugs, there is an English guideline called MODRIC, or Manipulation of Drugs Required in Children, which recommended that the tablet should be split in preference to dispersing or crushing and taking out a proportion. So a tablet can be dispersed and then you can extract the dose proportion. Then there are some national guidelines from the Nasjonalt kompetansenettverk for legemidler til barn, and then they suggested that the tablet should be dispersed and a dose extracted. So we designed 2 scenarios. We first dispersed the tablet and extracted a fraction of the dose. And the other scenario was to split the tablet and extract the full dose from the split tablet. And this was done in 2 different ways, which we come back to, because we first start with the first scenario, where the full tablet was dispersed in water and we extracted from different zones in medicine measure. The lower zone, very close to the bottom, was the zone 1, and we divided it into 5 zones according to the paper by Broadchurch, who had done earlier studies with ASA, which showed quite poor recovery of the dose also. And this is also what we found. The different colors in this graph is indicating the different tablets, and then we had different mixing with increased mixing moving from left to right. And we can clearly see that 2 of the, that not every tablet type achieved the 100% recovered dose. And it was the dispersible types that was the better. The chewable type and conventional aspirin was really not performing well according to this manipulation method. And for a pharmacist, this is not so surprising. I'm sure you're not very surprised by this finding, but for the nurses and the physicians in the department, they were rather surprised that they had been giving the chewable tablet and wanting to do the best for the child. I had even found the child adjusted dosage form, but when they wanted to manipulate, it's clearly shown that this was not a very good starting point. So the dose that we recovered, that depends highly on the type of the tablet. Also the mixing technique has an impact, and the combination of the two or the different tablets would respond differently to different mixing methods. And we extracted 10% of the full strength of the tablet. However, it's also shown that the accuracy could be quite good if you choose the appropriate tablet and appropriate mixing method for that type of the tablet for the manipulation. Then the next scenario was to look at tablets that are split before they are dispersed. So we split the tablet either into a quarter or into a half, and then we dispersed it either into 10 milliliters in a medicine measure or directly into an oral syringe. And we can see that, which has also been described earlier, but since we chose this method of manipulation, we thought it was appropriate to look at the splitting accuracy for the various tablets. And different tablets have different accuracy, and some quite weak tablets like this dispersible tablet. We had really the largest fragment is the one to the left, and then going towards the right is the smaller and smaller fragments. And we can see that dispersible aspirin had quite different splitting accuracy. And this tablet, none of these tablets has a score line, so they are not intended for splitting. But nevertheless, we chose the largest fragment for the further analysis. And here I show you some results from when we disperse half a tablet in a medicine measure and then extract and give the full dose. And some tablets behaved well, and some tablets were clearly not suitable for this type of manipulation, especially the chewable aspirin was approximately 70% when no rinsing was applied. When we rinsed the medicine measure, we came up to 100% recovered dose. However, the conventional aspirin never, even after rinsing, would show a good dose accuracy. But when we did the same experiment, when putting the half of the tablet into a oral syringe and sucking up water into the syringe and then redispersing it in the syringe, we could sort of save most of the dose. And also the conventional aspirin and the chewable tablet was performing better or well in this type of manipulation. Then we were a bit worried about ASA. I said it was a poorly soluble drug, and it is also a pH dependent drug. So if we go back, we can explain some of the behavior of ASA because of the pH that is provided. In the dispersible aspirin, the pH will be higher so that we are about the pKa of acetylsalicylic acid, and the solubility will be higher. However, in the chewable and conventional aspirin, we are below the pKa and the solubility is much lower. And then we thought, what about a drug with a very narrow therapeutic index? If we have so dramatic differences for aspirin, how will that be? And then we decided to look at warfarin because of the very narrow therapeutic index. However, warfarin is much more soluble. And with a more soluble API, the results are also much more in line. We on the Norwegian market, there were two different warfarin products, Mydavan and warfarin from Orion Pharma, and both of them behaved well in both of the scenarios. So what did we learn? Of course, as I said, very basic for a pharmacist, but of course, then the tablet type will be quite important. Some are more suitable for manipulation, some are less suitable. The solubility of the API has an impact on the recovered dose. It is much more difficult to achieve a high recovery of the dose if the drug substance has a poor water solubility, aqueous solubility. And the different manipulation methods can have some pros and some cons, and that can be different depending on the different tablet and the different API. But most frequently, the dispersion directly into the syringe is a better way of doing it than in the medicinal measure. And maybe if the doctors could prescribe doses that are not 18% or 32% of an adult dose, that would also help to reduce the manipulation errors. Was one recommendation that went back to the children's wards. But for us, this also emphasized that we really need better dose adjustment methods. And since we started working with 3D printing, we thought that this is also an area which should be studied much more closely for dosing to children. So I will not show you so much results from our 3D printing project because we are not that far yet, but we have established a collaboration with a kidney transplant department at the Oslo University Hospital. And the PhD student in this project is Bjarke Strøm Larsen from in my group, and he will then look at how can we, back to the kidney transplanted patients. They are a good example of a group of patients that is in need of dose adjustment during the therapy, because they will live on a lot of medication after having received a new organ, not to reject the organ. So they need some immunosuppressant drugs, maybe 2 of that type. They need some anti-inflammatory drugs. They need a cocktail of different drugs. And these drugs needs quite frequent dosing. They need frequent dose adjustment. There are generic variability in the enzymes that metabolize the drugs. And there are, as I said, different phases of the treatment. So what he will do, he will try to find ways of make flexible dose adjustments. We also want to prepare a printed product with an immediate release profile, but it's also desirable to have several doses in one unit so that we can have a pulsatile profile or release of the drug. And because of the many drugs that are needed for this patient and for the rest of their lives, a poly pill that would contain 3 to 5 maybe APIs, and most likely APIs with various release kinetics would be desirable. And then with our collaborators at the hospital pharmacy, we would aim for production at the hospital pharmacy. But we are far from there now. So there is still a lot for him to do. But I think it's an interesting case and gives us a lot of opportunities to try out different things. So that was my final slide, and I would like to acknowledge all the people that was part of the manipulation project from the hospital pharmacy side, the master students that have been doing a lot of the manipulations, and the team around Bjarke. I see I spelled his name here with a wrong letter, but we have a collaborator, Natalia Genina at the University in Copenhagen, and 2 colleagues at the Oslo University Hospital and hospital pharmacy.